Dear colleague, welcome to this tool and technique session sponsored by Terimo with a live demonstration from Massy, France. And this session will focus on the challenging topic of complex PCI in high bleeding risk patients. So when we speak about complex PCI in high bleeding risk patients, the first entity to discuss is the complex PCI. Because even if proposed in the guidelines, we still have today no consensual definition, and it's always a little bit subjective, while for one operator, what is complex is probably not the same thing than the other one. However, we know that we can define complex PCI as challenging anatomies like complex bifurcation, left main disease, multivessel disease, or even calcified lesion. So the second entity in the title of the session is the concept of high bleeding risk patient. And first, how to define HBR patient. We heard yesterday about the new HBR ARC definition, assuming that we also have in a group of HBR patients very different type of HBR. And it's a real challenge when we speak about high bleeding risk patients, because we know that many factors qualifying the patient as high bleeding risk patient will also be factors with high ischemic risk, such as chronic renal failure. And also, when we do complex PCI in high bleeding risk patients, we know that in daily clinical practice, it will be a kind of antagonist interaction. Because with the complex PCI, we would like to optimize both the intensity of duration of antithrombotic strategies, while the high bleeding risk profile of the patient will tend to choose for more short and adapted antithrombotic therapy. So we probably have also to try a new interaction, which is first to identify the bleeding risk of the patient, which will require adjusted antithrombotic strategy, and therefore tailored the complexity of the PCI performed for both the choice of the technique, but also the choice of the device we use, integrating the bleeding risk of the patient. And accordingly, the objective of this session will be first to identify HBR patient requiring adjusted antithrombotic strategy, to tailor PCI strategies to specific HBR patient for drug and device synergy, and to reflect how to select new generation drug-eluting stent in HBR patients. And the team for this session, I'm very happy to co-chair this session with Marco Valgimigli. We have great panelists with us, and we will have also a great team of operators in Massy. And the flow of the session will be divided with two live case procedures from Massy. The first one performed by Bernard Chevalier and Philippe Garot. Then we'll have a short presentation by my co-chair Marco Valgimigli, and then a second case performed by Thierry Lefebvre and Thomas Ovas. So we can now really enter the session and start with the first case presentation entitled Distal Left Main Bifurcation PCI, for which the operator in Massy will be Bernard Chevalier and Philippe Garot. So our patient today is a 76-year-old male with body mass index of 34. It's a diabetic patient, high blood pressure, ex-smoker, and patient with dyslipidemia. He has nothing significant in terms of lifestyle, and as other comorbidities, he has two very significant comorbidities. The first one is renal failure on hemodialysis without residual diuresis, and he has also COPD. As prior clinical history, this patient had last year in April elective PCI of the proximal LED, the marginal and the right with drug-eluting stents. And he was admitted again in November 2018 for a non-STEMI, showing an instant occlusion of the marginal, instant restenosis of the proximal RCA, and new lesion of the posterolateral branch. He was treated with drug-eluting balloon in the right and drug-eluting stent for the distal lesion. He was now admitted again in Massy because he was short of breath on A4 for a few months with class 3 NYHA. On the laboratory investigation, we can see a clear anemia and also a high creatinine. And for the non-invasive testing, he had in April, a few weeks ago, a good LV systolic function, normal RV function, and on the MRI performed, he has clear and severe ischemia of the inferior and lateral wall for 6 out of 17 segments. So here you can see the baseline angiography showing the instant occlusion of the first marginal branch, but also a distal lesion with involvement of the ostium of the LAD and the circ. On this view, you can see also what we could call intermediate lesion in the mid-LAD that we have also on this eleocranial view. And on the spider view, we can see that indeed the ostium of the circ seems to be involved in the distal left main lesion. We had also proximal to the stent of the right previously implanted a tight stenosis of the ostium of the right. So for the risk evaluation of the patient, Euroscore was 432, the syntax score was 31, STS was 2%, and the syntax score 2 was in favor of PCI for this patient. So just to summarize this case with the key clinical and angiographic data, we have a 76-year-old male, high blood pressure, diabetic patient with COPD and renal failure on dialysis. He has ostial lesion of the right, distal left main lesion which could be classified according to the Medina classification 111 with a mid-intermediate stenosis on the LAD. Marco?
Thank you very much, Thomas. I think it's time to go live directly, so it's my privilege to welcome Massy and our operators today. Bernard, can you hear us?
Hello to everyone. Welcome to Massy.
Hello.
We are very honored and very pleased to be in this session. I'm working today with Bernard Chevalier and Dr. Onuma, that you all know, who will be our expert in OFDI. We are working with our anesthetist, Dr. Messaada, and you have been aware of the patients. The presentation was done, so I think, Bernard, it's time to start with the tools and techniques and key objectives session.
Thank you. Good morning, everybody. Next one, please. So this is potential conflict of interest. The key objective of this first live case will be to show how to manage the complex PCI in high bleeding risk patients, the so-called HBR, to discuss the optimal PCI strategy in this left main, which is a 111 Medina, and to show how FDI will help us to facilitate and to optimize the outcome of this patient. As said by Thomas Cuisset, ostial RCA has been treated 2 days ago with Ultimaster device. We use the radial approach, the same left radial approach we used 2 days ago for the RCA treatment, because this patient is on dialysis and has a fistula on the right, AV fistula on the right arm. We are going to treat this patient in a provisional stenting approach with a left main to LED stenting and consider, if necessary, to do subsequent T or TAP if a second stent is necessary. We'll do OFDA assessment at the start of the procedure and after a full implantation of the device in order to check what we have done. And the patient will be included later on in the MasterAdapt trial as the screening process was fully compatible with inclusion and exclusion criteria. Next one. I will show you briefly the three tools we are going to use. The Ure balloon as a predilatation tool for this left main, which is a new balloon from Terumo with a modified tip and low profile and more pushability compared to previous versions. Next one. Next one, please. The AcuForce, which is a well-known non-compliant balloon with good crossability and capability for doing kissing with large balloons in a 6 French guiding catheter, which is the case of today. We use a 7 French in this patient to be comfortable for the pod, but we can use kissing in 6 French if necessary. And the stent will be Ultimaster Tensai, which is a new version of the Ultimaster, which has the same feature in terms of bifurcation capability regarding the access to the side branch, the opening of the cells, and the capability of further expansion in the proximal part of the main stent. So maybe you can show what we have done so far, Philippe.
Yes, so we have done we have been in the left main with the 7 French EBU 4.0, and prior to the live, we have wired the LAD and the circumflex with run-through coronary wires, and this is the first injection we had. So you can clearly see that the lesion is involving both the left main, but also the ostium of LAD and the ostium of the circumflex. So this is the view we have in a caudal view. And, well, yes, for sure, this is a 111 lesion. The left main is quite huge. The proximal LAD has some aneurysm, so it should be, we measured around 4 millimeters for the proximal LAD. The circumflex is around 2.5, and with the Murray law and all the law we have to assess the size of the left main, it should be a 5 or 5.5 diameter left main at the end of the procedure.
Okay, we have wired the 2 vessels, LED and circ, and I think it's now time to predilate because you can see that this lesion is very tight. And the flow was not totally perfect. Our initial plan was to perform the OFDI as a first step, but we think that we need to predilate this lesion with a 3.5 balloon. It's a 3.5 Ure by 15. In order to improve flow in the LED.
Bernard, Philippe, while you're working, let me kick off with one question. Based on the angiogram that we saw before going live, actually the stenosis at the ostium of the circumflex looked much less tight. Now, perhaps because of the wire already in place, this vessel straight a bit, and now the stenosis seems to be really very tight. So actually, I do agree with you that before OFDI, probably I would try to stabilize the lesion.
Absolutely. So we plan to start, with the OFDI, but as you can see, the lesion is really tight. We had a drop in pressure now, and we thought it's much safer to predilate and have a better flow in both branches. Okay, so we were at 12 atmospheres with the 3.5 balloon. We can assess the result after the predilatation.
And Bernard, you will do FDI left main LAD, or you will also try to check, because without predilatation, it will be challenging probably to go into the circ to assess also.
No, we are not planning to do OFDI from left main to CX. I think our main concern is to assess the diameters, the length of the lesion by OFDI. We want also to be to have some evaluation of the mid-LED lesion. But I think, considering the distal runoff of this circ, I think is no target for doing OFDI in this direction, at least as a first step. You can see that the pressure, which was a little bit low after wire placement, is much better now. So it was important to pre-dilate towards the LED. And we are now going to introduce the OFDI transducer. So, of course, we can raise the question of contrast injection in this patient because he has renal failure, but he has no residual diuresis, so I think there is no real drawback to use a significant amount of contrast in this patient. So, really, we can do what we plan to do in a normal way.
So let's discuss among the panelists the treatment strategy. We are in France, so of course they go for provisional. Honestly, probably in Switzerland I would have gone for a bifurcation stent technique approach, especially given the ostial lesion, the circumflex, and the tight angulation. Any comments from you, David, who are a very expert operating with bifurcation, a lot of studies?
No, well, I would definitely try and keep this as simple as possible. I mean, it's already been proved that he has had restenosis with stenting. So I think if you put 2 stents in the left main, you're really asking for trouble with restenosis. So I think I would try and keep this as simple as possible and put a single stent from LAD back to left main, proximally optimize it, and then do a kissing inflation into the circumflex.
So you're happy with the strategy. Andres, your comment.
Well, probably in my case, I will do T stenting with a T because of the angle of the circumflex in 90 degrees maybe. And I think the reason for choosing the multi-master stent is quite proper because of the high cell opening that might facilitate the entering in the circumflex artery.
Which is a good point, because ultimaster can be expanded up to 5.8, so it's basically the largest diameter you can reach with any commercially available stent. Stefan, your view, would you go for provisional?
I agree. Strategically, I want to keep it simple as possible, as quick as possible. With the angulation, I think that speaks in favor of a simple one-stent technique, but it may appear to be important also to stent the circumflex provisional T afterward. We'll see how it looks.
But probably also, Marco, I think they want to keep it simple because of the HBR profile of the patient. Even if it's not very HBR profile of the patient, you just have renal dysfunction, which is also a high risk for ischemic events. So that's also why probably they want to keep it simple.
Yes, I totally agree, and I think just to add the comment, you said we are in France and we will use only one stent, but I should say that this is our strategy, but we're not sure we will be using only one stent. Yeah. The point is that we want to start by the main branch, and maybe we would go for a second one. If we can do it simple, with less stent, less metal, it would be probably better with shortened DAPT, but if we have to, for sure, we will go for a second one. In our experience for left main lesions like this one, we will go with one stent in 70 to 80% of cases, so it's not so bad. We have less device and probably better outcome with shorter DAPT.
Yeah, Ron?
I think for us the main reason to go to a provisional approach will be the fact that the circ lesion is extremely short, so we think really we can achieve a good result with a single stent on the classical step of bifurcation treatment.
Yeah, Ron?
I think we have done now the OFDI run.
Can you see the OFDI?
Yeah, very well.
So maybe I can show the...
We cannot
hear you.
Oh, no, Dr. Rumo. Yes, now it's okay. Please go ahead, Yoshi.
Yes, yeah. Sorry, this is the pullback from mid LED, so I can just show the a little bit slowly the entire pullback. It starts from distal part, and it's diffusely diseased coronary artery. You can see that some calcification or the mainly fibrous plaque. There is one side branch coming, which is probably diagonal. There was a shorter stent, previous stent. It looks very short. I think it's probably 8 millimeter. I can make a measurement later. And then there is the area that was free from the stent again. And we are still in the stented segment. You could see the stent opens very well. Here is no stent. You see the calcification, 180 degree. Although it's not really entire, there's a two chunk of calcium, and there's another side branch coming. It's very huge coronary artery already in the proximal part of the LAD. You can probably see that. Probably it's already 4 millimeter. I think there was a dissection probably caused by the preservation. The tissue is more or less fibrous. We don't see too much calcification. Here we see some chunk of the calcium. And then here you see the other wire. So it's still, yeah. Thank you. So it's also a very large vessel. I think it's 5 millimeter in the left main. So maybe I can change. So yeah, if you look at the proximal part of the left main, it's almost out of the range of the scanning, but it's almost 5 millimeter in the proximal part. And so you see here, this is the circumflex ostium. So circumflex ostium is very much tightened. Yeah. And you see the wire from the circumflex is coming. So I think the opening of the side branch of the circumflex is very, very small. We can make one measurement. It's almost like, yeah, it's less than 1 millimeter. So it's very tight stenosis. We can make a measurement for the length of the stent. For example, if you take this one proximal and distally little bit proximal to the previous stent, or if you try to cover until the previous stent, it will be 20 to 23. You can take landing zone around here, which is already 4.6. If you try to do that just proximal LAD to proximal left main, I think that both diameter was 5.0, 5.0. So length is, if you have 18, probably will cover the entire part of this focal stenosis.
Yeah, that's what we planned to pick. It was a 4 by 18 Ultimaster tensile. We keep this strategy, Philippe?
Yes, I think so. I think we had very nice information from FDI. So we have the length and the mean diameter of the proximal LAD on left main.
4 par 18, vous l'avez?
4
par 18.
Bernard, Philippe? Looking at the FDI pictures, one of the colleagues in the room asked about the option to use rotational atherectomy for the left main after the OFDI finding. What do you think about this proposal from the room?
I think it's not so calcified. We have some spot of calcification, but I don't see something very challenging like a ring or even half ring calcification. I don't know what Yoshi thinks about this option, but for me, these OFDI findings are not promoting the rotational atherectomy. What do you think, Yoshi?
No, I agree with you, because I think calcification is more for the LAD part, and as you see that here in the left main, that it's not too much calcified. And I think, the most tight stenosis present in the fibrous tissue. It's not really the calcified. So I think we can avoid the rotablator in this case.
I think this is a very elegant demonstration of how useful FDI can be in planning the procedure. With respect to the landing zone diameter, I think we already have selected the stent diameter. I don't think we have any other choice but the 4.0 stent probably diameter.
Yes. So we select, as usual, the stent in reference to the distal diameter of the bifurcation. So it's easier the proximal LAD. So 4-0 seems appropriate. Another point which is very important is to have enough stent in the main part of the bifurcation to have the room for doing the pot, because the pot is important, needs transforming this one stent with one diameter in a one stent with two diameters in order to comply with the fractal law of coronary.
Ran, any comment from your side? You tried to comment, but it was impossible so far.
Yeah, I'm more concerned, I must say. I also would like to make it simple, but in order to make it simple, I would plan for a two-stent technique up front. I must say that, and it's a perfect scenario for a T-stenting because of the angulation. I'm very much concerned about the circ.
You will start left main LAD, Ron? Yeah. You will start left main LAD and then...
I would dilate both, place a stent in ostial circ, preserve the left main to LAD track, place a stent, rewire, kissing, and this is what I would do.
This is exactly one question we got from the audience. Why not DK crash? So meanwhile, you're positioning the stent?
In a high bleeding risk patient.
We know that
yes,
one of the things you're trying to do here is give this patient an opportunity to have short dual antiplatelet duration. So, you know, if you go with two stents, well, you're certainly not going to be very happy to put them in master DAPT and risk 1 month of dual antiplatelets only. So I'm fully with Bernard and Philippe in trying to keep this as simple as possible.
Well, I can reassure there, because we have already 300 patients actually with bifurcational stenting technique, and apparently things are going very well. So
sure.
We allow bifurcational stenting, and it's not absolutely an exclusion criteria.
No, but in this patient who's already had restenosis and has high bleeding risk, you know, you want to stay away from two stents if you possibly can, because that commits you to a longer dual antiplatelet therapy. You'll be less happy to stop.
With regard to the duration of DAPT, I'm more concerned about the final results than the technique. So as long as we are confident that we will achieve a good result, I would be happy. Yeah. And I think your strategy would be okay, and I think it's highly likely that they will need to put a second stent there, but there will be minimal stent overlap.
Because I know, Marco, it's reassuring, but it's true that if you end up with randomization with 1 month and DK crash in the left main, I will not feel very comfortable, I think.
Well, but we have already 50 patients. I look into that. We have already 50 patients in the study, so we have to stick to the protocol, and the protocol does allow that. If the study will deliver different signal, of course, I think we have to react upon it. But I do agree with Stefan that perhaps it's better to have an extra stent, but no residual stenosis, than one single stent and 90% lesion in the ostial circumflex.
No, but the great thing about the provisional strategy, which is pioneered by the Massey, is that you know, you do it stepwise, and at each stage, when you're happy that you've got the good result, you stop. And that may mean that you end up with two stents, but you don't start off by saying, we're going to put two stents. It means it's a very versatile technique.
So meanwhile, the stent has been placed?
Yes, in the meantime, the stent has been placed. At we have enough place to do the pot now. We can see that the circ is still open. It's still, I would say, a little bit better.
Right, I agree, Bernard, actually. Before. I was relieved after stent implantation. The circumflex actually improved, apparently, instead of deteriorating.
Yeah.
So you may have a point, actually.
And now we are going to do the pot. We have done the pot with 5-0. You can see if you have a pressure that the inflation in the left main are extremely poorly tolerated. Even very short inflation, we have a pressure decrease extremely rapidly, so we should be very, very fast, a little bit faster than we are usually.
Bernard?
But anyway, pressure is going up now.
Bernard, could you explain just the balloon positioning for the pot, you know, with the distal marker of the balloon regarding the carina, and because we were speaking too much
I think it's
during
important,
the pot.
of course. No, sorry, no problem. So I think we place the distal marker at the carina level, a little bit proximal to the carina. We don't go to be beyond. So the Acuforce has a very short shoulder. So it's the marker is really a good marker to place it. It's also important to have a good view, to have a good separation between the two branches, to be sure that there is no overlap between the ostium of the two branches. But clearly the position is to be just in front of the carina, and to be sure that you are not beyond the carina, otherwise you are counterproductive.
Bernard, Philippe, one question from the audience. Which anticoagulation regimen are you implementing during the procedure?
Patient has received 100 units per kilo of heparin with target ECT will be 300, so we have a very standard approach compared to usual PCI, and of course he was preloaded with dual antiplatelet therapy.
So this is the result after the pot. As you've seen, we have used a 5.08 millimeter long Accuforce in left main and LAD on the bifurcation to have this pot, and this is the result after the pot. Good news coming from the circumflex, that is, as you said, better than it was before starting the procedure. And the result is good on left main, I think, after the pot. We will check that with the OFDI. But if you agree, our plan is now to use a new run-through wire and go in the circumflex to access the circumflex and have a kissing balloon inflation.
So, yeah, please, André.
Yes. This case illustrates to me one situation that probably is not common, that consider that there is many other options. I mean, one option is to do the one stent and no more, because the flow is TIMI3 flow in the circumflex artery. Another option is to implant a stent in order to improve the result, but it's not so good because it's a 2 millimeters vessel diameter, more or less. But another option is to use the drug-eluting balloon in the circumflex. I'm not sure what are the best option, but it could be an option.
Absolutely. Actually, this is also one of the questions coming from the audience. What about drug-eluting balloon as a way to manage the residual stenosis in the circumflex? Bernard, Philippe, do you have experience? Would you like to comment upon it quickly?
I think, of course, it's a nice option we can discuss in this situation. To be honest, it's not our regular practice to use a drug-eluting balloon instead of normal balloon to treat the side branch. I think we need clearly more data to validate this option. And I think there is a need for randomized data comparing these two strategies.
I can comment. I'm sorry. Please. Sorry.
I'm sure that there is no data, or at least huge areas to confirm this option, but it's an option. But first of all, I would like to know what is the FFR in this circumflex artery, because it could be normal. So.
Yeah, this is a good point. Ran, please go ahead.
Yeah, I mean, drug-eluting balloons for side branch, there are some data, not good data. The technical issue is that the deliverability of drug-eluting balloon through stent slots is awful. So that's not a good strategy. If you plan a drug-eluting balloon, you should pre-dilate the side branch, then do the drug-eluting balloon, then place the stent, and then do the kissing, and not trying to get the drug-eluting balloon through the strut. That's not a good strategy, and it's also disrupt the coating, which is not a good thing to have.
I agree. I have that experience many times with the peeling off of the coating. Yes.
In this case, I think the background is the high bleeding risk, and the optimization of the result is really key. And I'm afraid a drug-eluting balloon here will not result in an optimal result. So I would favor a stent here, actually.
Yeah. Bernard, Philippe, we had also one of the usual questions we have for left main PCI is, should we put the stent up to the ostium? Because in this case, because it's a long left main, you stop in the mid-shaft of the left main?
Yes, I think the answer is in the hands of Yoshi Onuma, because clearly we see that the ostium of the left main is extremely large. Yoshi, can you comment about that?
Yes, yeah, I think you're right. I think the ostium of the left main is very large. I think it's more than 5.5. I think I think in this, yeah. So in the measurement, it's 5.4, 5.3 millimeters. So I think in this case, probably we don't need to cover because it will create a malapposition.
Yeah. I think there is no lesion at this part, and if we place a stent up to the ostium, it will be more difficult to get good apposition because we are very close to the limit of PCI balloons.
Yes, yeah, I totally agree.
Nicely done.
So I have to say that there is a very important angulation between LAD and circumflex, and it's quite challenging to cross. I've tried to go in the LAD with a U shape in order to avoid to go even after pot to go under the strut, and then pull back and have the distal strut of the stent and reach finally the circumflex. So this one is now the circumflex. So this one is the jail wire. I think we can keep it for now. And Bernard, what do you think? We can go now for the kissing?
I think so, yes. Maybe we can go back to the area view because this one is not
area view is better.
Very nice. What is important now is once you remove gel wires not to jump in the left main with a guiding catheter and to get longitudinal compression. I think it's a very important tips and tricks for this part. So we have selected 2.5 millimeter balloon for the circ, for the kiss, and a 4.0 for the LAD, which is the nominal size of the stent we implanted.
So for Dr. Onuma, there is an important practical question from the audience. We are sizing a stent based on FDI, but we know that there is some discrepancy between OFDI and IVOS, with IVOS normally reading larger diameters. Yoshi, can you comment upon this, and which of the two imaging technique would you believe should be trusted the most?
We don't hear you. Validated modality. Sorry.
Yes.
Can you hear me now? Can you hear me now? Yes.
Yes, very well.
So the OCT, OFDI is a very well validated modality in terms of the ex vivo study and also the in vitro study. So we know that the resolution of the OFDI is the highest amongst the imaging modality available in the cath lab. And we also see that the very accurate measurement in terms of phantom plexiglass model, etc. And also the clinical trial, we have seen that systematically IVAS is providing us a larger dimension compared to the OFDI. So I think in terms of measurement, OFDI is very well accurate. And so that when you use the OFDI or the IVAS in the left main, of course, we have this Kang's criteria to prevent the restenosis. It's a 8765 proximal main, polygonal conference, distal main branch, and side branch, respectively. And I think we can probably use a similar criteria for OFDI because the Kang's criteria is for the Asian population, and for the Western population, probably we should use the little bit higher cutoff. And by using the OCT in this H765, on IVAS, probably it will have a little bit larger dimension. So I think to use this criteria for the OFDI is probably a good way to it's at least a good cutoff to think about dimension after left main stenting.
All right.
Meanwhile, the 2.5 balloon crossed impressively easily, if I'm not wrong.
Yes. Absolutely. And as Bernard said, we have very good balloons, non-compliant but low profile, and it's quite easy to cross the strut.
But also it's because you did the pot nicely.
Right.
It makes facilitates the passage of a non-compliant balloon very nicely. Makes a big difference.
Makes room, yeah.
And Bernard Philippe, we had also a question about the new strategy pot side pot, but you still only do kissing in the left main for the provisional approach.
Yes, we still use traditional kissing because we think that it's not so easy to correct the distortion you create with the side opening. It's extremely easy to do that in bench test, but when you do that in real practice, you need to be sure that you are deep enough to correct the distortion, but not beyond the carina. So there is a margin which is extremely low, less than 1 millimeter, and the capability to do that in real life, in my opinion, is not very good.
Yeah, fully agree.
But would you restrict that strategy to left main standing, or would you extend that to any kind of bifurcation?
No,
approach?
I think for any kind of bifurcation, I mean, the difficulty is in that technique, which has never been proven in any kind of study, is that the final pot, the position of the final pot is so crucial as to what ends up with the neocarina, metal neocarina. So I think it's, it just hasn't been shown anywhere to be a good strategy yet. So I don't really know why it's gained so much chat.
Well, I guess bench testing, I guess, is the one.
Yeah, just bench testing, but then you can see exactly where you land your balloon.
That's a good point. That's a fair point.
I don't want to be rude, but I think it's a lazy technique.
That was quite rude, though.
Okay, meanwhile, I have to take my words back, because this ostium of the left main gets better and better.
Yeah. One practical point there, Bernard. Would you have used the same length balloons if you had them? Because I saw the kissing balloon, where they were different lengths.
Yes, our plan was initially to use 215, but the first 15 was no longer sterile. So we switched to a shorter one.
Switched to 8 millimeter
usually
one.
we use same length in the two branches.
Yeah, absolutely.
So next step for us is to do the repot, because we think that a repot is important to avoid this bottleneck effect we have with the kissing. I can see very, very well with OFDI, the bottleneck effect we create with a kissing balloon. And we need to do a repot, not too proximal. I think the most important thing is to be sure that you cover the very proximal strut.
Test.
So, Bernard, Philippe, it seems clear to us that you did not feel compelled to actually reach the ostium of the left main, which was not diseased, whereas many have discussed the need to at least reach the ostium, even if you are treating the distal left main. Has your practice evolved with that respect over time?
Usually, we really rely on the evaluation of the ostium. And if it's one of the added value of intravascular imaging, if the ostium is free of disease, if it's a very large ostium like we have here, I don't see any benefit to cover the ostium. I see even some drawback. First, the risk of malapposition, because we are dealing with very huge diameters. And the second drawback is the fact that if you do that, you increase the risk of longitudinal compression by the guiding catheter, because you are in a close contact with the first strut of the stent. What do you think?
No, Bernard, these 2 points are extremely well taken. There is a comment from Andres, I guess.
No, but is it not related with the fact that Bernard is telling us? I go back to the previous comment about the possibility to disrupt the polymer of the stent. And I think this stent is quite difficult because there is a well-wrapped polymer, but the drag is only in the aluminal surface. So I think the possibility to wrap it has less relevance than many other stents. So in my opinion, the risk is so low.
But I guess probably Bernard was referring more to the mechanical longitudinal strain, the concertina effect, more than just affecting the drug distribution.
Exactly. That's what I meant. I think it's now time for checking the situation with OFDI.
Right.
To
You have
wrap
10
up
minutes
the
left,
situation,
Bernard and
we
Philippe,
have
just for your information, 10 minutes left.
Yeah.
Okay. So we have done a report to correct the bottleneck, as Bernard said, and now I'm going with the OFDI probe in the left main and LAD, and we will have to discuss the result of our left main with this runoff.
And do you want to use the OFDI
So we have done
for the mid-LAD lesion as well, Philippe, Bernard?
Yes.
Yes, that's what we plan to do.
Maybe I should go a little bit distant for that.
The total length of the run could be up to 15 centimeters, so meaning that can really
Okay, it's covered.
have a very long,
Maybe.
can really have a very long evaluation.
Yeah, it's covered.
So to summarize, we have done the different steps we initially planned, so stenting to LED, doing a pot, putting a third wire, doing the kissing, and doing a repot. And now we have to check the situation.
Okay. So.
We have a proximal malposition.
Okay.
Est-ce qu'on peut avoir le ballon de 5,5
Yeah, I think FDI here was quite useful even post-stent implantation.
Yeah.
It's again a good example that
it was very
angio.
quick, but
Yoshi, can
it
you
was very quick, but you
Yeah.
can really see.
Yoshi, can you walk us through the most relevant findings of FDI, which are really impressive here, I would say?
Yes. So just
Speak close to the microphone because otherwise, yeah.
Yes. Can you hear me? Okay. Oh, okay. So this is a pullback from the distal part. I think maybe I will just skip a little bit. So there is some stenosis in the mid portion of the LED. I think I will make one measurement here. It's a 1.88, so you can argue that this cutoff to predict the FFR positive is 2.0. So I think 1.8 could produce the ischemia after that. But I think most important findings is in the actually the proximal LED part. You could see that there was a lot of Marapose strut here. This is a proximal LED. You can see the significant malposition, which is extending around almost 270 degrees. So I think we definitely need to post-dilate here. And also, I think that there was under expansion of the stent around here. And now it's circumflex wire is coming. So opening of the circumflex looks somewhat okay. And lumen is the, I think, still a little bit ellipsoid, but I think in the proximal part, especially, it is round and circular. Maybe let me check the expansion of the stent around just beyond the bifurcation carina. So it is 3.49, and I think reference diameter of the LED was 5 millimeters. So I think we need to improve the proximal LED stent.
Yeah.
Yeah, so it's more the proximal LED than
So
the left
clearly
main.
we need-
Yeah.
Yes, and actually you could see it on the angiogram as well, couldn't you, really?
Okay. So Yoshi, for you, we have to use a 4.5 or 5.0 for proximal LED?
I think a 5.0 will be appropriate because this is a 4.8, and I think we need to go up to at least 4.9.
I think it's a very impressive findings because we can really see how suboptimal was the result in terms of deployment, despite a very good angiographic follow-up.
Yeah.
One of the advantage of this stent, Bernard, is that you might reach 5.5 millimeters of expansion, so probably it could be enough to expand properly the stent in the proximal part of the LED.
Yes, I think it's a very important thing to, when you select the stent, to consider the capability of over expansion, because you can see that sometimes you have to be bigger than you think initially. So we are now placing a 5.0 in proximal LED.
It's nice because on the angio it's quite unusual, huh? Bernard, to use 5.0 in the proximal LED if you don't do imaging. Huh?
No.
On va faire un stent de 10.
Absolutely. It's very classical for X-Men, but not from proximal LED. But you can see on the angio that there is a kind of aneurysm in this part.
From the beginning, we had this big aneurysm.
And I guess you took a non-compliant balloon,
Yes,
right? Not a compliant balloon to avoid the...
Yes.
Yeah.
Yes, for sure. Okay, can we check the position maybe?
Okay. So we have the stent magnification coming, but we also have a test, and I think it's good, considering the position of both wires and the markers.
D'accord.
Test.
Okay. Un petit test. Small test. I
Okay,
think you
c'est
should
bien.
go a little bit more
A
distal.
little bit more distal.
Yeah.
I think it's okay here.
You can see that, like always in bifurcation, you should not rely only on the wires. They are not good markers.
Okay, vas-y.
And do you have stent boost or equivalent in this case to see if there is no under expansion of the stent, maybe on the lesion here?
Yes, I think we have a stent V's in this cat lab, of course.
Yeah.
But I think we need to consider for malposition detection, you need to inject contrast because if you do only stent V without contrast, you only detect under deployment of the stent, which is not the case. The case is fully deployed, but not at a good diameter.
What was the pressure in the balloon there?
It's fully circular.
Was 16 atmospheres with a 5.0.
And the good thing of Ultimasa stent that it's also pretty much radio opaque, so actually you do see it, perhaps even without stent boost, actually. It's just one of the distinguished features of the stent per se.
By angiography, it looks better. I think we should do another run.
Yeah.
For the mid-LED, I think the size was 3.2 square millimeter, if that's correct, something like this.
There was a point where it is a 1.88. So
MLD, but in area it's 2.8. Huh?
yes, yeah, right, yeah, you're right. It's
So 2.8
2 minutes to go,
is
Bernard.
usually,
Okay.
yes,
Let's put
we
some
are
pressure.
just checking the OFDI.
Yeah, sorry, I think my comment was wrong. If it is the square millimeter, it's significant.
Yeah.
But if it is a millimeter, yeah, I think probably it's not producing a scheme. Yeah, so
Yes, I think we don't have argument with 2.8 to go directly to the stent. I think we should probably postpone that and consider a non-invasive evaluation later on. You
yes.
agree with that?
Yeah, I agree with that. I think. that
Yoshi,
we
are you
should-
ready for the final run?
Yes. Yeah, I'm ready.
It's going very fast, but looks better, no?
Yeah.
Yes. So I think the Mara position was improved, but the quality of the image around the Mara position was not so optimal. I see the improvement of the expansion, apparently distal LED. So this is the circumflex coming from the 7 o'clock. And just distal to this circumflex, I think we don't see despite the quality of the imaging, we don't see the significant Mara position, and it's really improved. And I think we can probably end the procedure because I can make a measurement. Let me see the measurement.
So while we are doing measurements, this is the angiographic result running on the screen. I think, Bernard, we can say that we have treated this distal left main lesion with one stent. It was really challenging because of the anatomy. We had some aneurysm, big diameters, with the help of OFDI and a stent positioning and sizing according to intravascular imaging and good techniques with spot kissing with one stent. I think we have a good result for both branches. And I feel quite confident for the follow-up. We will have DAPT according to the MasterDAP trial. And as Bernard said, for the middle AD lesion, I think we will have to reassess in some weeks or months, in absence of symptoms, the presence of significant ischemia or not. Bernard, do you want to?
Yes, I think it's, you can see that, if I'm correct, the osteum of the lady is 20 square millimeter, which is a good result. I think probably it's a good sign for a low risk of restenosis in this patient. And I think it's a good demonstration that our web DI could help us to do a single stent strategy in this kind of complex lesion.
I personally agree. I think we really show a fantastic demonstration that FDI really changed your treatment strategy. On the other side, using clinical grounds, of course, you know that you don't have to follow 100% the images, and I would have not used anything bigger than 5.0 in the proximal AD, even if you have some minor degree of residual malapposition. But I guess from the safety standpoint, I think you're doing the perfect choice for the patient.
It's also a great demonstration.
Thank you very much for your nice comments.
Yeah, thank you, Bernard and Philippe. It's also a great demonstration of how crucial is it to optimize the result of the PCI in patients in whom we have to stop the APT at 1 month. So using the good device, the good technique, and imaging also to optimize the apposition. So I think a great demonstration for this specific patient as well.
Perhaps a last quick comment and a question from my side. I have always been challenged by many femoralists saying that, especially in patients with CKD, where there may be need for fistula, and that was clearly the case in this patient, you should never use the radial artery to spare the possibility that the artery will be used later on as a fistula. You selected the left radial on purpose because on the right side there was already a fistula, but of course we know that fistula are prone to occlusion. Does that impact your decision making for the access site, or you think it's a trivial point?
No, we think it's a trivial point, and even the nephrologists in our team are pushing that for using radial approach because they experience that using radial approach we have less vascular complication. These kind of patients are very risky in terms of vascular complication if you go to femoral approach. So we are doing that at the request of nephrologists.
And for these specific patients, the body mass index is above 40, and the risk of femoral complications was really too high, and that's why we decided to go through the left radial system.
I am 100% with you.
Okay, so I think we can close the case and thank you both Bernard, Philippe, and all the team, and Dr. Onuma as well. Thank you.
Great case, guys. Thank you.
Thank you very much.
Nice job.
It was a pleasure.
So now it's my pleasure to introduce my co-chair, Marco Valgimigli, who will speak about the current landscape of research in HBR patients undergoing PCI.
Thank you, Thomas. Good afternoon, everybody. Quickly, my disclosure. So I have a difficult task because I would have a lot of things to say, but let me try to summarize things. First of all, starting from what is known. We have today 3 completed studies, actually, focusing on the eye bleeding risk space, and which are in chronological order. The ZOO study, which was the first to pre-specify the inclusion of HBR patients who were randomly allocated to current generation DS versus Endeavor Sprint zosterolone-eluting stent, which was associated to a lower TVR, MI, and stent thrombosis. Then the pivotal riddles-free study came with as many as almost 2,500 patients, all of them HBR, randomly allocated to DS, drug-coated stent, or Gazelle, and that also was showing lower TVR and lower MI, both of them under a fixed 1-month EPT duration. And most recently, we have seen the senior study with 1,200 elderly patients randomly allocated again to biodegradable polymer EES versus the corresponding bare metal stent. Again, the EPT duration was fixed, either 1 month in stable or 6 months in ACS patient, and also this study was showing lower risk of TVR associated with the DS iteration of the stent platform. Now, to the best of my knowledge, we have today 18 studies running in this space, which means either the patient are still being conducted, the patient are still being included, or follow-up is still running, or at least the study has not been published. 7 of which are randomly controlled studies, 18 are single-arm registries. The study objectives can actually be summarized pretty much in these 2 bullet points. From one side, to define the technology-specific optimal DAPT duration, or for one of these studies, type of the APT comparison. On the other side, to establish the value of coronary artery devices, specific coronary artery devices, or in a way, treatment strategy, if you will, for obtaining revascularization in HBR patients. Now, quickly walking through the single-arm studies, we have today 3 ongoing studies, namely Evolve Short DAPT, POEM, or St. Ivo's DAPT, which are investigating either 3 or 1 month DAPT duration after a Synergy stent implantation without or with mandatory IVOS assessment at the time of stent implantation. Elunir HBR is about 316 patients who are receiving Elunir stent and then are receiving 1 month of DAPT if stable or 3 months DAPT if unstable. Finally, Panelux PTCA. It's a new exploration of a new treatment strategy, I would say, with systematic routine prokinetic BMS implantation followed by a Panteralux, so drug-eluting balloon inflation inside the previously implanted stent, followed by 1 month DAPT in patients who were deemed not eligible for DES. Now, to keep on going with the single-arm registries, we have the Onyx one clear. It's about 800 patients receiving Resolute Onyx implantation followed by 1 month DAPT. We have 3 large studies, namely Science 28 Global, Science 28 USA, Science 90, which are investigating the safety of either 1 month, which could be as short as 28 days, that's where the name is coming from, or 3 month DAPT after Science stent implantation. Leaders Free 2 was presented last year at TCT, not yet published. Leaders Free 3 is still running. The goal here is to actually assess the safety of 1 month DAPT followed by, which follows actually Biofreedom, Biolumin 9 drug-coded stent implantation. Now, quickly walking through the landscape of randomized control studies. 2 of them are pretty small, power for mechanistic endpoint, so forgive me if I will not be expanding on those. In the popular age, the focus is actually on elderly patient more than HBR per se, and the focus is not really on the APT duration, rather on the APT type, newer P212 inhibitor versus clopidogrel in a patient presenting with ACS. Onyx 1 is soon to be reported, most likely TCT this year, where 2,000 patients have been randomly allocated to Onyx, the autonomous eluting stent implantation versus Biofreedom BA9 drug-coded stent, and the power and endpoint for which the study's power will be MACE on an inferiority endpoint. Cobra Reduce is focusing only on OAC patients, where the Cobra stent, which is a BMS with a polymer coating, actually, which is not releasing any drug, followed by 14 days of DAPT, is being compared to any second-generation DES, followed by either 3 or 6 months DAPT. Finally, the only 2 studies which are being conducted at this stage, which are investigating indeed the optimal DAPT duration after 2 specific stents in patients who are deemed at high bleeding risk, namely the Firehawk stent DAPT study and the Master DAPT study, which I will be expanding on shortly. Just to give you a snapshot about what HBR criteria all the studies are going for. From one side, we have popular age. Actually, the only criteria is age itself, greater than 70. On the other side of the equation, we have the Cobra Reduce, which is only recruiting patients who are in the need for concomitant oral anticoagulation. And then we have the 3 studies, Master DAPT, Onyx 1, and Firehawk stent DAPT, where you do see that actually the definition of HBR is pretty much heterogeneous and based on the fulfillment of at least one of these single individual criteria. Having said that, I think it's worthwhile emphasizing that specifically for the Firehawk ORC stent DPT studies, also some criteria which in my understanding have really nothing to do with HBR features, such as female with AS or congestive heart failure with reduced LV ejection fraction, are also making patients inclusion possibly. Now, quickly to close with, let me show you the study design of these two randomized studies, which are really focusing on optimal DPT duration on HBR patients. Let's start from the FIRE-HORC stent DPT study, which is a prospective multicenter double-blind randomized study, again focusing on HBR patients. The target sample size is 1,720 patients. Randomization is going to be 1:1 to either 1 month DPT or 6 months of DPT, only consisting of aspirin and clopidogrel. The target population is pretty much a stable CAD patient population. As you see, ACS patient is belonging to the exclusion criteria, and within these selection, actually very complicated procedure or very complicated anatomy are also fulfilling exclusion. The primary point is going to be a NACE endpoint, so a combination of ischemic and bleeding events at 1 year, which is a time frame in which actually starting from 6 months onwards, all patients will be receiving aspirin monotherapy, irrespective of the original randomized allocation. Now, MASTI DPT is about 4,300 patients who are going to be recruited, who are being recruited actually across as many as 130 international sites. The patient has to fulfill a HBR condition, at least one among those I was showing just a few minutes ago. Then the patient, as long as is consenting into the study, is entering a so-called running phase, consisting of 1 month of mandatory DPT, and then the patient is really getting into the study with the random allocation according to a 1:1 ratio to either abbreviated DPT or prolonged DPT, with the primary endpoints being NACE on a non-inferiority endpoint, if met, MACE on a non-inferiority endpoint, and finally, if met, major or clinical relevant non-major bleeding, which will be tested, in fact, on a superiority endpoint. Now, quickly to show you what the experimental and the control arm are about. In the experimental arm, after randomization, the DPT regimen is immediately stopped, and the patient is continued with a single antiplatelet therapy, either aspirin or P2Y12 inhibitor, at discretion of the treating physician. Whereas in patients in whom there is also a concomitant indication to OAC, in fact, SAPT is also discontinued 5 months after randomization, which means 6 months after last stent implantation. In the control group, this protocol does provide lower limit with respect to DPT duration, but not upper limit of DPT duration, meaning that in patients without OAC indication, a DPT regimen is to maintain in place for at least 5 months after randomization, whereas in patients with OAC, so who are receiving, therefore, a triple therapy regimen, DPT should last at least 2 months after randomization, meaning 3 months overall after last stent implantation. Let me close quickly by emphasizing some unique features of the MASTI DPT study. It is based on the cleanest possible study design, which means in my mind that in no study phase, the experimental therapy matches the control one, and actually this is pretty much reflected by the large sample size. Unlike many other studies in this space, we do see that the non-inferiority margins are pretty much stringent, in a way, if you will, pharma-like, which is also reflected by the large sample size. Importantly, the experimental arms mitigates not only 1 month DPT duration, but also dropping concomitant APT in OAC patients. And actually, this is a feature which has never been investigated before, and the only all-comers HBR trial, actually, because this is the only study where no exclusion are presented based on presenting syndrome, complexity, location, number, or planned treatment strategy of the target lesion. And with that, I would like to thank you.
Thank you, Marco, for this great overview of existing and upcoming evidence. I think the team is ready in Massy, so we can now move to the next patient presentation.
Very quickly, it's going to be another case of unprotected left main. He's a relatively young gentleman, age 69. Male, also telling you, fit. As a risk factors, we have hypertension, non-insulin dependent diabetes, and ex-smoking activity. The high bleeding risk status of this patient is indeed fulfilled by the fact that this patient has a history of atrial fibrillation in the need for oral anticoagulation with rivaroxaban 20. The patient has a stable presentation with angina class 2 as well as dyspnea, also class 2. I would say that laboratory investigation is pretty much unremarkable with a very good metabolic, I would say, control despite the non-insulin dependent diabetes. A quick look at the EKG, atrial fibrillation, I would expect some massive degree of ST segment depression in anterior leads. The patient also underwent an exercise stress echo, which was negative for symptoms, positive for EKG changes, and also positive for some new wall motion abnormalities in the territory of the LAD and the apex. And quickly, this is the baseline angiography, which is clearly showing a tight lesion in distal left main, which is again loading again. And please appreciate the same lesion in this cranial view. This is really a very tight lesion. I think we have no doubt about this. Also, this patient had the mid-RCA lesion, which was, however, already treated, as I was telling you before. Logistic Euro score is 3.6, syntax score is 16, and the syntax the score 2 calculator is projecting the Fourier mortality risk of 21.5% for PCI, 32% for cabbage. As I was already anticipated, this patient received recently a single Ultimaster stent implantation for the treatment of RCA. So this is the key clinical angiographic summary, and I guess with that I hand it over to you, Thomas. Thank you very much.
Thank you, Marco. I think now it's time to go to Massy after this case presentation, and I think that Thierry Lefebvre and Thomas Vass are now ready to start and present the first part of the case.
Thomas?
Hello.
How are you? How are you?
Hello, Thomas. Hello, Thierry. Hello, all the team.
Okay.
Hello.
So Thomas will be the operator. I'm just here for assisting him, and we have a very good nurse. Will do the same. We have also Dr. Onuma on board for the OFDI evaluation. And before that, I will just tell you what is tools and technique. So if we can have the slide. Okay, so we have a patient with high bleeding risk patient, as you will see, as you have already seen, and the objective of our live case, the second one, is to show how to manage complex PCI in this kind of patient, to discuss about optimal PCI strategy in left main Medina 100, and of course to show how OFDI may help to facilitate and optimize the procedure. So Thomas, maybe you can explain what we have already done.
Yes, so at this point we have right radial 6 French.
Can we have the global image?
Slender sheath. We have an extra backup for 6 French in the left main, and we perform.
Can you show Thomas, please?
We already perform 2 orthogonal view after nitrate injection. So this is the first view. So we saw the left main lesion, and the second view, which is more interesting. Okay, this one. So I think we have a first question for the panel and for sure the audience about this lesion. Do you think we can avoid the bifurcation, and will you try to put a stent just on the lesion without treating the bifurcation? And after this question, we will show you the result of the OFDI with Dr. Onuma.
Maybe we can ask the panelists. Ron,
Ron?
do you think we can avoid a bifurcation here and just put a stent up to the distal left main?
I think so. I think this is one of the unique cases, which is not infrequent, where the angulation would allow to place a stent right at the inlet of the bifurcation. I've done not a lot, but several of these cases, and I think it's feasible. And if you try to do that and it works, it's an asset. And if not, you still can, the bifurcation is there, so you can really manage beyond that. But I think the likelihood to succeed with a stent up to the bifurcation here is around 80 to 90%, to my understanding.
So angiographically, it looks possible, but I suspect the OFDI will suggest to us that it's not a good idea.
So maybe not to do an OFDI.
Okay, good. So any other opinion about this, the strategy for this case?
Thierry, I would never try to avoid the bifurcation. I would do a crossover stenting here. I think the landing zone of the stent is too short. Normally, my safety margin is at least 2 millimeters, and geographically speaking, if I don't use OFDI or CT or IVOS, and I don't think we have these two margin here.
And in some cases, if you try to avoid the bifurcation, you will do the bifurcation in few months.
Yes.
So
Yeah. So can we continue with the slides, Francesca? The tools and techniques slides, please, Francesca. Yes. Next one. So, of course, we'll do OFDI because we are not sure that we can avoid treating the bifurcation. So it was suggested by Ran, we don't do OFDI, but I think it's very important if we can treat the patient with one stent covering the bifurcation and use only one stent is better than using two. Next slide, we have use run-through wires, which is our workhorse wire in Massey. Next one, we'll use a Riure balloon, which is an excellent balloon as compared to the Tazuna balloon, as you know. And we'll also use Ultimaso stent. So while I'm speaking, Thomas is putting a second wire in the circumflex.
Yes, I think it's a first good message for colleagues is even for Medina 100, even if you don't want to treat the bifurcation, the second wire is really a good marker to put the stent. So I think two wires are in this case very useful, whatever the strategy you choose.
So Thomas, your message is that even if you avoid the bifurcation, you will put the wire in the side branch. Well, I think it's a very important message because in many cases when you try to avoid the bifurcation, you regret to have done that. And in this particular case, we'll check by OFDI how is the anatomy of this patient. So Dr. Onuma, if you can show us the OFDI.
Yes. So can you see the screen? And yeah, okay. Can you hear me?
We do.
So you have a good connection now with OFDI, Francesca. You can you don't need to use the camera, but the connection that you have had.
Okay. So maybe
we do see the screen.
Can you see the
images.
OFDI?
Yes.
But okay. So it disappeared.
Okay. So it is a pullback from the mid-LED. You can see that there is a diagonal branch coming into this lumen, and it is a diffusely diseased plaque-rich coronary artery, but there's a small calcification, but it's only extending 90 degrees. Here you see there's some kind of the calcium extending 180, and then the lumen becomes somewhat ellipsoid. But there was some good probably we can use it as a landmark landing zone of the distal stenting. There is a intermediate branch coming, and then now you see the circumflex is coming, And just before the left main bifurcation, there's a severe stenosis, which is visible on the angiography. But I must say that the plaque is really extending from the left main towards the LAD, and I don't see that any possibility of landing zone in the left main. I think the landing zone should be the LAD. Maybe I can go back to the image, and also we did some measurement in the proximal left main. You can see that proximal left main sizing of vessel is 4.5, 4.6. You can go to this. Now I'm proceeding to the LAD direction. This is a MLF, which is very small, 1.5 in diameter. And then suddenly after this stenosis, there's a circumflex coming. So actually, we don't see any possibility of the landing zone in the proximal LAD left main. And I think we should land in the LAD proximal. And here is probably the good landing zone. Still, you have a plaque, but there's not so much stenosis. So and the measurement of the vessel is a 4.0. So I would recommend to crossing over, and distal size is a 4.0 millimeter in diameter, and proximal is a 4.5.
Okay. So thank you very much, Yoshi. I think this information is very important. We are suspecting that on the angiogram, but it's nice to have the confirmation that it's better not to avoid the bifurcation in this case. We know the distal reference, which is around 4.0. We know the proximal reference, which is around 4.5.
Yes.
And the length of the lesion also can be measured. That is about 18 millimeters, something like that. So, Thomas, what do you plan to do now?
So, as we just discussed, we have no landing zone, and even if we add 1 or 2 millimeters landing zone, I would consider it tricky to because when you have a landing zone of 1-2 millimeters is one thing, but to put the stent at this exact place is quite another. So I think it's more safe in this case in particular, and in many other cases to treat the bifurcation. So as you can see, we put a second wire in the obtuse marginal branch, and now with also the result of the OFDI showing a very fibrous lesion, we will make a predilatation.
So Francesca, can we see the setup of the table with the 2 wires on the table and the balloon? I think it's very important in order to avoid wire wrap. Perfect. So in order to avoid wire wrap, so we have the LED wire here, the circ wire here, and in the middle we have the 3.5 non-compliant balloon, AQ-force, to predilate this lesion.
Okay, so that's a 3.5 balloon. You can see it's undersized comparing to the left main. We are at 16 atmosphere. Okay, off.
You have a 7 French guiding catheter, right?
6 French.
6 French.
6 French. Okay.
Yeah. We decided to use 6 French. It's not as compared to the other patient where the left main is more than 5 millimeter. It's close to 5.5. We think that when we have 4.5 or 4.0, 6 French is okay, especially when the side branch is small. So in this case, the circ is about 2.5. So it's not an issue to work with 6 French when you have 4.0 in the LED and 2.5 in the circ.
Okay, so let's take the stents. So everyone is okay for a 4.0 stent?
Yeah, so we have predilate with 3.5, 16 atmosphere. We have, of course, the result is not perfect. So we put a stent and we select a 4.0 21. 4.0 is the diameter of the proximal LED, and of course it will be too small for the
Thierry, Thomas, while you
left main.
While you open the stent, we had many questions from the room about also the antithrombotic strategy, meaning did you stop the rivaroxaban before? What is the regimen during the PCI? We had many questions from colleagues in the room through the REACT system.
Yeah. So Thomas, do you want to answer to the question?
No, but
Yeah, so rivaroxaban was stopped, but I think we could also continue rivaroxaban and leave the patient on triple antiplatelet treatment for the procedure. And then the patient will be included in the Ultimaster study. Is the Master DAP study, sorry. Yeah. So we'll continue the APT for a short time.
Depending on the randomization, probably.
Exactly, of course. But it's a short time, even if it's in the randomization, it's relatively long, it's relatively short.
Okay.
Absolutely.
So at this point, I'd like to go to do two views to assess the proximal position of the stent in this view. Okay. And
Looks
maybe
perfect,
go on a cranial view for the distal position on
so
the
we'll
LED.
check also in cranial view that you are not touching the bifurcation with the diagonal branch.
How did you come to the conclusion to use a 21 millimeter balloon? It seems that you could have used a shorter if you wanted to have a short, or prolong it in order to cover the entire left main.
Yes. So we checked the measurement by OFDI, and the measurement by Dr. Onuma was about 17 millimeter. So just in order to have some margin, we'll decide to use the 21.
So maybe, what do you think of the position? Maybe I can go back for 1 millimeter to be, or is it okay?
Maybe 500 microns.
I think it's perfect. I would leave it like that.
I think I will go back.
Okay.
Best landing zone is 5 millimeter from the left main bifurcation carina. So,
because at this point, I'm really at the junction between the aneurysm and the normal LED. So maybe half a millimeter, as Thierry said. Anti-test?
Yeah.
Okay, like this. Okay, excellent. Okay, yeah.
So Thierry, we have seen the baseline EKG, and we keep seeing the EKG right now with quite impressive ST segment depression. The question is, do you think that's a reflection of ischemia, or perhaps it's an effect of digoxin and possible intoxication, which is also a question coming from the audience?
It's a good point. I think it's a good point, and we checked that, and it was in the normal range.
Okay. So as you can see, the stent is opening. The pressure is still okay, but dropping slowly and slowly as usual. But try to keep at least 15 or 20 seconds, even for left main, to let the stent
so as you know, we like very much to have long inflation, even for the left main, because time is our friend in terms of stent apposition and deployment.
It was quite a dramatic effect of stent implantation and pressure, as expected, of course.
But I think we saw Thierry wait and try and keep the stent up for as long as possible. But then once the pressure starts to drift, that's the time to
exactly.
Fade. Yeah.
Yeah, exactly. And of course, if you have not enough time, you can post-dilate second time with the same balloon. So 2 times 20 seconds is better than 1 time 10 seconds. So,
would you feel confident to do direct stenting once you have seen the OFDI images, or would you rather prefer to pre-dilate irrespective? Question from the audience.
That's a very good question.
So Thomas, maybe you can answer to this question. I think it's
because in this case, important. With the OFDI, we could say, okay, the direct stent implantation could be possible, but we don't perform OFDI for every patient, and the 2 main reasons to use a predilatation is because of the fibrous lesion, which can help after for stent deployment. And second, and more generally, it will give you a good assessment of the length and the diameter of the artery. So predilatation is very useful to assess your measurement in many cases.
So now Thomas will post-dilate at least the proximal part of the stent just before the carina with a 4.5
Okay. We can make an angio before the pot, if you want. Okay, so this is the first angio.
Okay. So we can see clearly that we are a little bit undersized, proximal to the carina. So now with the 4.5, we'll be able to have a stand which is well expanded and well opposed.
So we have to go with the marker of the balloon up to the carina.
Yeah. Okay.
Test. I think it's okay here. What do you
think? So
think?
maybe we can ask to David, because Dave, you like very much to have a perfect position for the balloon.
Yeah,
Is it
I think.
Okay for you?
Yeah, probably, but I'd like to see the marker right at the end of the bifurcation. Sometimes I'll go LAO caudal to take another projection and see whether we're right at the carina.
So you place the distal marker in the mid of the side branch.
Distal marker at the carina.
Yeah, at the carina. So maybe it's not enough. We'll see.
No. Yeah.
Okay, so maybe 1 millimeter more.
Yeah.
It's a 4.5 balloon, huh?
Yeah.
Okay. Yeah.
4.5, yeah.
Yes.
Yeah.
Okay.
Okay, perfect.
Inflation.
So Thomas pushed a little bit the balloon by 1 millimeter in order really to be at the level just proximal to the carina. You know that these Teremo balloons are very short shoulders, so it's very useful. So 4.5 can go to 8.
So we have the chart of the balloon. So we are at 16 atmospheres. That means the balloon should be at 4.63 millimeters. So it's okay.
I will go to 20.
20?
Yeah.
More? Okay, let's go.
20. Okay.
So again, the pressure is starting now to drop, so we will deflate the balloon. Okay, off.
And then post-dilate a little bit more proximal, I think, Thomas?
Yeah.
That's so we have this part that you're just about to do is something that people often forget to do, isn't it? Come back a few millimeters and make sure you post-dilate, you proximally optimize the whole stent, not just at the bifurcation.
Yeah. Exactly.
Okay, so I will do an angio without injection to be sure that my balloon is within the stent.
Perfect.
Okay. Inflation.
That's a beautiful distance.
So 12, 18. What we can do, Thomas, maybe it's a stent boost.
Yeah.
Stent vis for the G room.
No. Okay. And let's do for a stent vis at this point to see if we correctly open, see if we project the strut towards the circ.
So make some.
So is this patient already taking aspirin and a P212 inhibitor, or would you rather load the patient after the procedure?
He's already on top of DAPT.
Ouais. C'est bon, merci.
So we'll do the stent vis.
C'est bon?
It's a good way to check that the optimization is okay. Okay. And Thomas, so the next step is to open the strut. So maybe we can discuss about that with the panel and the room. We think it's better to open the strut toward the circ, but of course we are fully open. So what is your opinion of the room?
Maybe we can look at the angio at this time and then ask the panel what they will
Thomas,
do.
we'll do an angio and. I think the angio will be good, but yeah.
I think it's
thanks to the pot, we have already a good result in the circ.
Yeah, it's quite difficult, I think, this issue, because you know, although you think, oh, it would be nice to have clean access to the circumflex if necessary thereafter, you know, you whenever you deform the main vessel stent, you don't completely correct it with the kissing inflation. So you do definitely lose something by opening the struts into the side branch in the same way as you may gain something. Personally, I might be tempted to leave this one alone.
I agree. The result is so good that I will not touch it anymore, to be honest.
But apparently, I think Thomas will try to do something.
What gives you?
I think it's a big discussion. And, we have no study showing. So no study was done to look at that. So we don't know. I think in favor of not doing it, as it was said by Dave, you may lose something, but at the same time you may gain something also, because if the patient is coming back in 3 or 4 years and you have to treat the marginal branch,
so at this point,
then it will be difficult.
At this point, we can perform an angio to be sure that we are in the distal strut. Okay, it seems perfect. Nice.
Yeah. So
very nice.
We are close to a very distal strut. I think it's okay.
Okay, let's do it again.
Turning wheel,
You were,
you know that. So Thomas likes very much to do what he called a turning wheel. So you engage the circ, and then when you are engaged in the circ, you just turn a little bit in order to have this kind of prolapse.
So he likes it so much he wanted to show it to us twice?
Okay. Yeah. Okay. Exactly. So maybe a small angio.
Do you think we can also say that the circ is not a side branch like any other side branch, and meaning for the future there is probably more value to do kissing, like we could do for a small diagonal, for example?
Yeah. No, of course, of course. So I was saying that there is some drawbacks, but there is also some advantages. The other one is that now we are seeing a lot of cases, not in my center because we open always a strut toward the circ, but we see a lot of cases with a pseudo-restenosis of the circ, which is just due to neo-endothelialization of the struts which are not open. So we have seen that with BVS, of course, and Dr. Onuma knows that very well, but we see that also with metallic stents. And these patients should be treated just by opening the strut. But because they don't do intracoronary imaging, they don't know if it's restenosis or just a membrane of endothelium which is covering the ostium.
Okay.
So for this reason, I think it's a good thing to open the strut. But of course, there is no study showing that it's beneficial or not.
Yes, Andres.
Okay. Yeah. Thierry, we have seen the elegant technique and mainly a safe technique for the patient to solve this type of lesion, but only for the caution. What do you think to another option is to treat this distal lesion in the left main, like if the lesion was in the mid segment of the left main, trying not to enter the stent in the LID, put the stent or the border of the stent at the border of the carina, making open the LID and the circ.
Yeah, but we have seen that there was too much plaque at the level of the bifurcation, and it was not reasonable to stop the stent before the bifurcation.
Yeah, but
of course you can try to do it, but you are always disappointed when you do it.
Yeah, but when
according to what we have seen on the OFGI.
But when you predilate, you demonstrate that the probability of the shifting of the plaque to the circumflex is quite low.
Yeah, of course, of course. I fully agree. So now we'll use a non-compliant balloon for the circ, 2.5, Thomas?
2.5 for the circ and 4.0 for the LED.
So we have 2.5 balloon non-compliant for the circ, a short one, 8 mm in length, and 4.0, 8 also.
No, I think I'd rather use a quite a longer balloon because with 8 balloons they are slightly to move.
Yeah. Okay.
So, question for the panel coming from the audience. In this case, rivaroxaban was stopped. What about if you don't stop NOAC and you actually let them go through? How do you dose unfractionated heparin at the time of PCI? Standard dosing, you go on the lower range?
Standard dosing, I think.
I completely agree. There are no data, and actually I would go for standard dosing. There is only one small mechanistic study, but it's not supportive at all that you can actually replace unfractionated heparin with rivaroxaban.
Yeah, I fully agree with you. Our friend, our EP guys are using this technique, so they do not stop NOAC when they do EP treatment. And the risk of bleeding is very low. So I think it's a very reasonable approach. So it's not 8 millimeter balloon, Thomas?
No.
Okay.
I don't like 8 millimeter
Okay.
balloon.
So maybe you can pull back a little bit the balloon in the circ.
I think the circ is not so bad. LED is a little bit.
So we just want to open the circ.
Okay, un petit test.
So perhaps while you are completing kissing balloon, let me ask a question to Yoshi again coming from the audience. We discussed before the disagreement between IVUS and OFDI or OCT. Can you elaborate on the fact that when you do OFDI measurement, you go from intima to intima, when you go for IVUS, you go to media to media? What is the best approach there?
Yeah, thank you for this very good question, and I think we don't have so much answer to that. I think the way is that we can use both. I think in terms of the bifurcation, most important thing is that you have to always modify the shape of the device according to the conservation, the flow of the bifurcation. So you have to take a large proximal diameter and smaller distal diameter. And of course, we have this Illumin 3, which use the like IVUS media-to-media measurement, and opinion trial use the lumen area. So I think we can do both, but I think we should be also consistent in the methodology, and especially for the bifurcation in left main. Sometimes you don't see the media-to-media because the vessel is too large. So I would use the lumen dimension rather than the media-to-media measurement, especially for the left main bifurcation.
Thank you.
I hope that.
Okay, so what we'll do now is repot, because we have done kissing balloon inflation above the polygon of confluence, so you may have a bottleneck effect on the stent with the kissing with long balloons. And then we'll close maybe the case with a final OFGI evaluation.
Thierry, maybe just one word for the kissing. You did sequential inflation and...
test?
Yeah, I prefer to do it, but I think that Thomas has done simultaneous inflation. But of course, simultaneous deflation is the most important. Yeah. So we know that Thomas, in the bench, if you do sequential inflation, especially starting with the side branch, you have better position of the stent in the bench. In the patient, maybe it's a little bit different.
Okay.
So I prefer to do sequential inflation and simultaneous deflation.
Yeah, we discussed with the first case the difference between the bench and the patient for even for the pod side pod strategy or the kissing. So it's
Thierry, another question coming from the audience. Why not using OFDI to judge whether you need to do strat opening towards the circumflex? And let me expand on this. Why not using FFR, functional significance of the residual lesion?
But I'm sure that FFR will be negative. So the problem is not to have positive or negative FFR. It's just to open the strut in order to have an optimal rheology, optimal access for the patient in the future, and no risk of colonization of the strut by neoendothelialization. But FFR, I'm sure that FFR, even before kissing balloon inflation, will be negative.
I agree. And also the cost is difficult to justify to take a FFR wire just to assess the side branch. And as you said, we are not opening the side branch because of the hemodynamically significant lesion, but just to keep the access. So
Yeah, okay. Yeah, of course. But sometimes you may have a very significant lesion of the side branch just because you push the carina, for example, or because there was a lot of disease at this level.
Okay, just a moment, sorry. Okay, yeah. Yeah, you can go.
It's not bad, huh?
So what do you think?
So,
Minor malposition, but not bad, eh?
yeah.
I think we have a good result, but Dr. Onima will show us the
Yes. So,
OFDI data.
So I think we see some malposition in the distal part, just the landing zone. I think it's, maybe we can make some measurement, but I think it's not so significant.
Go to the rear.
And I think the opening of circumflex is quite big. And let me show some measurement. But I think there was a minor malposition in the distal part of this landing zone of the LAD, but I think it's quite minor. It's probably less than 400 micron, and the extension is so it's 0.27. So I think we will be sure that at follow-up it will disappear naturally. The opening of the side branch is quite open, and we don't see any metallic carina, so I think the position of the wire was quite good, taking a distal cell. And proximal part also, we don't see any significant malposition. And there was a small, intimal rupture, but I think it's in the end of the strut, there's no dissection. So I think it's a quite good result.
Okay, so at this point, I will do 2 more angio for you. Maybe we can do nitrate. It's nice because the pressure is very good, so I'd like to do that before finishing the case. And so the only things to think about is do we need to make another post dilatation at the distal part of the stent? Okay, allez. Okay, and let's do maybe a spider view.
Beautiful result.
Okay, so the
wonderful. Yeah.
So at this point, would you do another post dilatation at the distal part of the stent, or would you let it like this?
No, I think it's fine. I don't know if there is another view in the panel, but
I think it's an excellent result, and I'm happy with the dilatation of the side branch. In this case, it's so large, and for future access, I think it's nice to have it opened. And
although it seems that everybody is happy with your result.
Okay, me too. Perfect.
and I have to say, using OFDI is important to know when to react and when not to react, because sometimes you oversee things, so you need to learn when not to overreact.
So I think Thierry is already in the time to react room, and I will join him in a few minutes. So I would like again to thank all the team in Massy for the preparation of these lives, and Sophie and Patrice, we were with us today. Thank you.
No,
see you in a moment.
Very nice case.
Donc en régie, je suis prêt.
Thierry, thank you very much for joining React at PCR. Can you hear us?
Yeah. Thank you. Yes, very nicely.
So I guess there are still a lot of questions actually googling around the fact whether we should or we should not do kissing balloon. Perhaps we can wrap up a bit. So the question is, in which case, when you have a wonderful angiographic result, would you avoid doing kissing balloon? Would there be some cases, or would you do it routinely?
Are you talking about left main or bifurcation in general?
So the question is generic. I would say let's stick to the left main, which is the lesion that we have in front of us now.
Okay. So for the left main, we always open the side branch, except if you have a less than 2 mm side branch, maybe it's different. But when you have 2.5 or more, I think the side branch is very important. You have seen that there is 3 marginal branches in this patient. And the patient may have a problem in the future. So we prefer to have struts which are open for the future, for not only for this reason, but also for the other reason that I told you, also the risk of poor rheology, which may promote atherosclerosis in the side branch or even in the main branch. The risk of neo-endothelialization of the struts, which are not open, etc. So for this, for the left main, we always do it. And when it's a routine, it's very simple to do a final kiss because you do it in few minutes, and when using a non-compliant balloon, the risk of increasing the need for a stent in the side branch is very low.
And Thierry, technically speaking, could you just also summarize the few key points for the kissing balloon, meaning the choice of the balloon, positioning, sequential inflation?
Yeah. So it's a very important point also. So we use non-compliant balloon for the side because there is no stent in the majority of cases, and semi-compliant usually or non-compliant in the main. And then we do the kissing starting with the side. In the bench is better, but of course we don't know in the patient. So starting with the side, inflating the main, and then a relatively long inflation if we can, so at least 15 seconds, but better to use 30 seconds or 45, and then deflate both at the same time. So now we have Dr. Onuma on board, Thomas, and we can answer to other questions.
Wonderful, thank you. Is the osteum of the side branch, meaning in this circumflex, in a way affecting your decision making with respect to single or bifurcation stenting technique, or you would try to go for a single stenting, provisional, let's call it in that manner, stenting approach irrespective of the osteum of the side branch?
Yeah, of course we can treat 111 lesions with a provisional side branch stenting approach. The risk of needing a second stent is higher. But when the lesion is very short, the risk of needing a second stent in the side branch is very low. So I don't know, Thomas, if you want to add something about this question, but this is a philosophy of provisional. So provisional does not mean that you will use one stent. It means that you will start with one stent in the main branch, and then, if needed, you will add a second stent in the side branch. And when you do that, in fact, the need for side branch stenting is low. Of course, if you have a long lesion, like in the DECA-CRUSH 5 study, for example, there was a long lesion in the side branch that you cannot treat with balloon. 17 millimeter was a mean length in DECA-CRUSH 5. So, of course, you need a stent in the side branch in this case.
Yeah, for short lesion, I think we can treat most of the patient, maybe 80 to 90% of the patient with only one stent, and the technique of provisional T is really simple, and you can adapt the technique during the case. So it's really the way we like to do this kind of patient.
Yeah. Perhaps going Along the same direction, another question is popping up. What is the chance of restenosis of the side branch when doing kissing without a significant lesion?
Not really overreact on some of the findings of the OFDI. Last year, we had a consensus paper on the OCT, and we just make a recommendation if the malapposition distance is not greater than 400 micron and with extension of 1 millimeter length, probably we should not really overreact to post-dilate. Also, same for the dissection. So I think that's important to know the what we should do after the OFDI.
Yeah, I fully agree. Yeah. So can you repeat the last question? Excuse me.
Sure. I think also there is a lot of question coming up with respect to why we are not implanting a second stent once you have touched the side branch with the balloon. I think the concern here is once you have a damage with the balloon, if you don't stent the lesion, the chance that that lesion will progress towards a restenosis is very high. Actually, I think we can reassure because we have a lot of data. In fact, you don't have acute stenosis. Actually, we do see, even after balloon inflation, that there is a positive remodeling, so that lesion actually is improving over time, not doing the opposite.
Yeah, I think we see every year we have this kind of question, and I can reassure you that when you use non-compliant balloon, the risk for needing a stent acutely or a follow-up is very, very low. So it's just opening the strut toward the side branch to have an optimal flow in the side branch, optimal rheology. So it's not because you have opened the strut that you will create damage to the vessel and create a new lesion at follow-up. We do not see that. And on the opposite, when you use a second stent, it's not a guarantee that you will not have restenosis at the side branch ostium. And maybe it's even more risk of restenosis. For example, with the Deca crush technique, we see a lot of patients coming back with restenosis at the ostium. And one of the hypotheses is coming from data from cardialysis, showing that when you have two stents, without stent, there is a lot of movement between the LAD and circ. And if you have two stents, there is a risk of fracture of the stent and a lot of conflict at the ostium of the side branch, which may promote restenosis.
And Thierry, Thomas, coming back to the main topic of the session, it was a great illustration that in high bleeding risk patient, when we will stop the APT earlier, we need really to optimize the result. But just also a question from the room about the choice of device in this specific population. Do you think there is important the choice of device in high bleeding risk patient? The stent?
Yeah, we try to use a low-profile stent with a thin strut, and which will permit us to stop DAPT quite quickly, earlier. And for sure, this patient we don't need to go for 12 months DAPT. We can really do a shorter duration. Yeah. And in this particular case, the master DAPT study will tell us
what is the optimal,
what is the duration we need for this patient.
Especially if you are able to use only one stent, it's easier to stop earlier the DAPT than if you have two stents, especially if you have special techniques.
So how are you now treating this patient in the next days before randomization? Is triple therapy up to 1 month? And then depending on randomization, what is the plan?
Yeah, exactly. So we'll start again the rivaroxaban with the DAPT. And according to the randomization, we'll stop aspirin or Plavix. And what we like to do is to check by a multiplate analysis at 1 month if the patient is sensible or not to Plavix or aspirin. So sometimes when we have some resistance, we stop aspirin or either Plavix depending on the result. Okay.
So Thomas, Thierry, we don't want to lose you, so we would like to thank you and congratulate again for this great case. So thank you very much.
Thank you. Thank you.
Thank you very much.
Thank you. Bye-bye.
Bye. I will give the final word to Marco.
Thank you, Thomas. Thank you, everybody. I think it was two very nice live cases demonstration, how the intersect between ischemic and bleeding risk can actually be tackled quite nicely, trying to be as gentle as possible, try to use and select stents which have proven safety, and try, of course, not to leave disease behind, because otherwise you will reach the opposite. So let me thank all the panelists and the operators for this fantastic case, and thank you very much for attending the session.